Hello, my name is Ian McCall, and this is the webinar for the Learn Dermatology blog, Module 13, Tuesday. Okay, two cases. The first one, and unfortunately I can't enlarge these images on this preview version, I've said is this scanning or non-scanning alopecia. What conditions would you consider in your diagnosis? What investigations do you carry out in your treatment? At this level, or at least at this magnification, you can't really tell. You can see that there's hair loss here. It looks as if there's a bit of redness and inflammation. But remember, some men that are bald, if they've got hair loss like this, and they're going out and getting some sun on the skin, then these areas will go red anyway. So you've always got to watch that it's not sunburn. You look to see if there's inflammation around the hairs. You look to see the bald area. In a scanning alopecia, you lose the openings of the hair follicles. You don't have the little infundibula of the hair follicle there. There's no opening. It's smooth, it's glazed, it's shiny. So if you look in there and you see this is smooth, glazed, and shiny, then it's a scanning alopecia. Scanning alopecia means the hair follicles have been permanently damaged. There's no hair follicle there. There's no hairs going to grow there. You then look at the periphery of the involved area and you see what's happening. You look to see are there any pustules there. If there's pustules, then it may be folliculitis decalvans. If there's a bit of perifollicular plugging, some scale in the surface, then you're looking at lichen planopilaris or lupus, discoid lupus. When it's a more diffuse area like this, it's more likely to be lichen planopilaris. Lichen planopilaris is just the other name for lichen planus affecting the hair. And it's generally more common than lupus is. So what do? You go looking elsewhere. You check and see if there's any evidence of lupus elsewhere. Is there any evidence of lichen planus elsewhere? Lupus is going to be in your sun-exposed areas. Lichen planus is going to be, your purplish papules, itchy papules, usually around the wrists, or the hypertrophic lichen planus in the lower legs, or you look in the mouth and you see if you've got the lacy white reticular pattern there as well. So once you've looked elsewhere, the next test you're going to do is a biopsy. Don't just take a biopsy of the scarred area, or if you are, take two, because you're just not going to see anything here. You want to go more towards the edges where there's still activity. And you want to take two biopsies, one for horizontal sectioning, one for vertical sectioning. And you want the pathologist to be able to show you if there's any evidence of lupus or lichen planus. Now, lichen planus will tend to hug the epidermis. It does involve the follicles, but not to the same extent as lupus. Lupus will go right down the follicles and cause damage there. So the pathologist should be able to tell the difference between lichen planus affecting the scalp and lupus. To some extent it doesn't really matter because your treatments are going to be the same. Both of those conditions are inflammatory conditions, and so you want to try and shut them off. And the way to shut them off is going to be either with, or both, topical corticosteroids such as Novacin lotion, rubbed in twice daily, or some intralesional steroid. You'd take the Kenacort A10, dilute it to 2.5 milligrams per mil by using 1 mil of Kenacort with 3 mils of local anesthetic, and you'll inject small amounts around the periphery of this. You're trying to shut the process off. You're trying to stop it expanding anymore. You'll do that a couple of times. So you see them back a month later. You see how it is, see if the inflammation is less. If it's not, you put another injection in. You see them back another month after that, and if it still hasn't stopped the process, then you consider using the drug Plaquenil, hydroxychloroquine. Initially, it's around 200 milligrams per day, increasing to 400. And remember, the big side effect with Plaquenil is damage to the eyes. So, choroiditis. So they've got to get their visual fields checked before they start, and then get them checked 3 months later. Because with hydroxychloroquine, you've got to use it over a 3 to 6 month period to assess its effectiveness. If you've got really extensive discoid lupus in the scalp, then probably a short course of oral steroids is the best way to try and shut it down. And then look at your topical steroids, sun protection, all the rest of things as well. but a short course of oral steroids over a 3 to 4 week period, starting at generally the 50 milligram level and tailing it down pretty quickly to nothing at the end of about 4 weeks. You're not going to have any problems with anyone using it in that particular way. Those are the major things, and those are the major treatments. You should probably, if you're considering lupus, you should just do the ANAs and the ENAs, just see if they're positive. Most cases of discoid lupus, and your ANA and ENA may not be positive. Even your immunofluorescence in the scalp is probably not worth it in this circumstance, because, as I say, it's more likely to be discoid than systemic lupus. The other scarring scalp conditions, I think we did that as an MCQ question last week, where we looked at, I think, the sclerodermoid variant of PCT. We talked about some of the other infective conditions like Kerrion that can leave scarring, folliculitis decalvans. I've mentioned with the pustules around the periphery. And if you culture those, you'll grow staph. And those patients usually need some form of oral antibiotic to keep the whole thing under control. It seems to be some curious hypersensitivity reaction to staphylococcus, but it does give rise to a slowly progressive a loss of hair. Clindamycin lotion can be used in the longer term to try and keep it under control. You may read about pseudopelade of Brock, B-R-O-C-Q. I think he's probably another Frenchman. But again, this is just an end stage of lichen planopilaris or discoid lupus, when all the inflammation's gone and you're just left with these white scarred areas. Remember, alopecia areata does not give scarring. You may have complete hair loss there, but if you look in, you'll still see the openings of the follicles there. That's the big difference. That's why you've got to look for that in any area of hair loss. If the follicle openings are still there, it's not a scarring alopecia. I think that's most of really what I wanted to chat to you about on this particular one. So the main things: lichen planopilaris, discoid lupus, biopsies, and the other intralesional steroids and topical steroids that we spoke about, and check the skin elsewhere. Now, case 2. What are we dealing with there? Is this pigmentation worrying? Would the history help? How would you investigate this, and what diagnosis would you consider? Well, the pigmentation is worrying. Here you've got a linear area of pigmentation here. And what you really want to know is, how long has that been there? Is that new or not? Because if it's new and you've got this linear pigmentation, then your big concern is, does the person have a melanoma here in the nail matrix, right at the base of this? Is there involvement of the posterior nail fold and the lunula here? Is this, well, it has to be the posterior nail fold, not just the lunula, not just the cuticle, I should say, because that's Hutchinson's sign. Now, usually in a melanoma of the nail like this, the defect is in the nail matrix. The melanoma is in the nail matrix. Now, if this had been long-lived, then it suggests that it's part of a nevus. But by that, I mean years and years. But if it's just short-lived, months or just a couple of years, then you'd have to consider that this may be a melanoma. And you effectively have to biopsy back here, because that's where the matrix is. You can either take a punch, a 3mm punch, and go straight through that, or you can reflect the skin here and selectively then punch without the overlying epidermis. But you need to go pretty deep, almost down to the bone, and it's not an easy area. If you reflect this, you can actually do an incisional biopsy into the matrix here and close it. But most cases, if you're doing a 3mm or less punch, you won't leave any permanent defect there. Acromelanoma is not a good thing. A dermatoscope, by the way, will help you. Looking at these lines with a dermatoscope, if you've got lines of varying thickness and depth of color, then that also is highly suggestive of a melanoma. Whereas if the lines are of uniform thickness, uniform width and color, then that's generally a more reassuring sign. But I still wouldn't bet my life on it. It's really history. Any new linear pigmentation like this needs to get a biopsy done, and especially if it's got a positive Hutchinson sign with pigment coming back into this area here. So either a nevus or a melanoma, but melanoma highly suspected. Occasionally, you'll get a bit of linear pigmentation from a fungus. But that, again, looks different under the dermatoscope. So the main issue here was the need for biopsy. You don't watch these. If it's a new lesion, you really get concerned about them. I'm sure I've probably dealt with more material in the podcast itself. Thank you very much.